Welcome to the Culture of Healthcare Evidence-Based Practice. This is part 5 of our series. In this session, we explore what it means to work in a healthcare setting. We'll look at job expectations, how care is organized within different practice environments, and the crucial role of privacy laws. We'll also consider the professional and ethical issues that healthcare professionals encounter in their daily work. And by the end of this session, you'll have a clearer picture of how the culture of healthcare shapes evidence based practice and influences patient care. The objectives for evidence based practice through the lens of clinical engineering are going to be the same as the previous one, which was to describe how EBM can be applied to key questions of diagnosis, harm, and prognosis. And when looking at diagnosis, engineers evaluate whether diagnostic technologies like ultrasound, MRI, or AI driven software deliver accurate and reproducible results. When we're dealing with harm, engineers assess device related risks such as alarm fatigue, radiation exposure, or software failures. When we are talking about prognosis, engineers help determine how technology influences long term outcomes, whether advanced monitoring systems improve recovery rates or just the quality of life. With that said, let's go ahead and begin. Evidence based practice in clinical engineering, harm and prognosis. So, we're turning to the two remaining types of basic clinical questions, harm and prognosis. So, let's start with harm, again, also called etiology. The central question is what causes a disease or complication? Causes can come from the environment, like air, water, bacteria, chemicals, or radiation from the sun. They can also come from what we do in medicine. So, for example, a diagnostic test, a device, or intervention that may have unintended complications. The challenge is not simply noticing that someone with an exposure gets sick, but asking whether those with the illnesses had a higher rate of exposure compared to those without the illnesses. Take this example. Just because a person who uses a cell phone develops brain cancer doesn't prove that the phone caused it. To answer that question properly, the gold standard would be a randomized controlled trial, splitting people into exposed and unexposed groups to see what happens. But here's the problem. If the exposure might be harmful, like a chemical suspected of causing cancer, we can't ethically assign people to receive it. That's where we move to the next best evidence, observational studies. Observational designs allow us to investigate possible harms without deliberately exposing people to risk, but they also come with limitations. Bias, confounding factors, and weak associations can all cloud the picture. So, in clinical engineering and in medicine, the key is knowing how to interpret observational studies carefully so we don't draw the wrong conclusions about harm. Examples of questions about harm. Over the years, many questions have surfaced in both the medical community and the news media about whether certain exposures actually cause harm. One example dates back to the 1990s when concerns were raised about silicone breast implants. Some women who had implants developed autoimmune diseases such as lupus and rheumatoid arthritis. But when researchers looked closely, they found that these diseases did not occur more frequently in women with implants than in those without. In other words, implants and autoimmune disease happen to occur together in some women, but the implants themselves didn't appear to cause the disease. A very different story unfolded with anti obesity drugs in the same decade, specifically fenfluramine and phentermine, which are, um, well, we'll leave it at that. But it was often called fen-phen. And in this case, research showed that people taking the drugs actually did develop heart valve abnormalities at a higher rate than those who didn't. That's a true association, one with important safety consequences that led to these drugs being pulled from the market. More recently, other questions of harm have come up that are particularly relevant to clinical engineering. For example, do ultrasound contrast agents cause kidney damage in patients with impaired renal function? And evidence shows that patients with kidney disease who received ultrasound contrast agents did not develop renal complications at a higher rate than those who did not receive them. Another thing is, do CT scans increase the risk of developing cancer? Studies of children and young adults exposed to repeated CT scans revealed a small but measurable increase in cancer risk, particularly leukemia and brain tumors, compared to those who were not exposed. So these examples highlight why careful study design and interpretation are so important. In one case, a perceived risk turned out to be unsupported. In another, the evidence confirmed real dangers that required actions. For clinical engineers and healthcare professionals alike, this reinforces the value of evidence based practice when evaluating whether a device, drug, or intervention truly causes harm. Hierarchy of evidence for harm. So, when we're assessing studies of harm, it's important to remember that not all evidence is created equal. There's a hierarchy of study designs that tells us how much confidence we can place in the findings. At the top of the hierarchy are randomized control trials, the gold standard. When ethical and practical, they provide the strongest evidence about whether an exposure or intervention causes harm. When randomized trials aren't possible, we move down the hierarchy to cohort studies, which follow groups of exposed and unexposed people over some time. And below that are case control studies, which look backward, comparing those with a disease to those without to see if exposures differed between them. And finally, at the bottom are case series and individual case reports. Like, well, these are valuable for raising initial red flags. They provide the weakest form of evidence since they don't establish whether the exposure truly caused the harm. So, the stronger the study design, the more confidence we can have that an observed association is real and not just coincidence. Let's talk about evidence and its limits. So, first, cohort studies in assessing harm. So, while randomized controlled trials provide the best evidence for harm, they're often impossible or unethical to conduct. That's why we turn to other types of studies, one of the most important being the cohort study. A cohort study is prospective. We take a group of patients who have been exposed to something, say a drug or environmental factor, and we follow them forward in time, comparing outcomes with a group that wasn't exposed. The key difference from a randomized trial is that the groups aren't assigned by chance. Cohort studies are especially useful when poor outcomes are rare. Take, for example, upper gastrointestinal bleeding caused by NSAIDs, non-steroidal anti-inflammatory drugs like Motrin or naproxen. Uh, this complication is serious, but it's relatively uncommon. Running a randomized trial to detect such a rare event would require an enormous sample size. So instead, a cohort study allows us to track real world patients and detect those rare harms. But there's a catch here because there's no randomization. The groups may not be comparable. Patients taking NSAIDs, for example, often have ongoing medical problems that require pain management. And those differences in health status can bias the results, making it harder to isolate the true effect of the drug. So, while cohort studies can provide valuable insights, they also remind us to interpret the evidence with caution. I don't know why I just said without caution. With caution, of course. Always asking whether the differences we see are due to the exposure itself or to the differences between the groups being studied. Continuing with evidence and its limits. So, case control studies and assessing harms. This is another important type of study for assessing harm, and it is the case control study. In fact, this is the most common form of observational study and the one most often used when we need answers quickly. So, here's how this works. Instead of waiting years for a prospective study, we look backward. We start by identifying people who already have the disease or condition, the cases. Then we find a group without the disease, which we call the controls, And by comparing the two, we ask, was there a different rate or amount of exposure between the cases and the controls? For example, case control studies showed that women with lupus or rheumatoid arthritis were not more likely to have had breast implants than women without these conditions. That helped settle the concern that implants were causing autoimmune disease. Case control studies are especially valuable when the condition is rare or has a long development time. So, a famous example is the discovery that the drug deaths prescribed in the 1950s caused vaginal cancer in women years later. That link could only be uncovered by looking backward at cases at their exposures. So the trade-off is that, like cohort studies, case control studies can be affected by bias and confounding, but when used carefully, they provide a powerful tool for connecting exposures to outcomes, especially when time or rarity makes other study designs just impractical. Benefits and limits continued. So the pitfalls of case control studies. One of the challenges with case control studies is that they can sometimes create spurious associations, connections that look real but turn out to be misleading. A striking example comes from a study once published in the New England Journal of Medicine, which claimed to find a link between coffee consumption and pancreatic cancer. And because it was published in such a prestigious journal, the results carried a lot of weight. But there was a problem. The researchers had chosen the wrong control group. They compared people with pancreatic cancer to people with other gastrointestinal diseases. And here's the catch: many gastrointestinal diseases, such as gastroesophageal reflux, are actually worsened by coffee. So people with those conditions tend to avoid drinking it. That meant the control group drank less coffee, while the pancreatic cancer group drank more. On the surface, this kind of looks like coffee was causing the cancer, but the reality was much simpler. People with reflux disease avoided coffee, while people with pancreatic cancer, they could tolerate it. I personally hate it. I don't like coffee. But when the study was repeated later with the proper control group, the supposed association between coffee and pancreatic cancer disappeared, and coffee drinkers everywhere could breathe a sigh of relief. So, this case shows why study design matters so much. Even in top journals, weak methods can lead to misleading conclusions, and this reminds us to interpret case control studies with care. Evidence and its limits continued. So, case series and case reports, the lowest level of evidence. At the very bottom of the hierarchy of evidence are case series and even lower, single case reports. And the problem with these types of studies is that they have no comparison group. Without a comparison, it's impossible to know whether the observed outcome is truly linked to an exposure or simply coincidental. That doesn't mean case reports and case series are useless. They can be valuable for generating hypotheses, raising red flags that researchers can later test with more rigorous study designs, but on their own, they don't provide high quality evidence. A classic example of this problem is the drug bendectin, which was introduced in the 1980s as a treatment for nausea in pregnancy, because giving any medication to pregnant women requires caution. Benedictine became controversial when a case series of birth defects appeared. So even though the evidence was weak, the publicity was so damaging that the drug was withdrawn from the market. So ironically, Bendectin contained two agents, this excuse me, doxylamine and peroxidine, and both of these, which were effective, and neither caused harm. Um, yeah, neither of them caused harm, but both of them were effective. In fact, some women benefited because one of those agents was actually a vitamin, but the case series alone was enough to trigger fear, and an effective treatment was lost for years. So it wasn't until uh, 2013 that the FDA reapproved those same two ingredients, reformulated in a delayed release pill as a first line treatment for nausea and vomiting in pregnancy. And this story is a cautionary tale. Case reports and case series can spark concern, but they should never be the sole basis for major medical decisions. You need stronger evidence, and that stronger evidence is always needed before changing practice. Pure prognosis studies are rare. So, prognosis studies, let's turn now to prognosis. One of the first things to understand is that it's actually difficult to conduct a strong prognosis study. And why is that? Well, because prognosis refers to the natural history of a disease, how an illness unfolds over time without intervention. But in today's world, there's very little that's truly natural about disease. In almost every case, we intervene, whether with diagnostic tests, medications, surgeries, or other therapies. And that means most studies of prognosis are actually looking at patients who have already had some kind of test or treatment. So, for example, we may measure prognosis in a group of patients who've been diagnosed with a certain condition or in a group that's received a particular treatment. When we do that, the line between prognosis study and the treatment study starts to blur. In other words, understanding prognosis isn't just about watching disease unfold, it's about interpreting outcomes in a world where medical interventions are almost always part of the story. Prognosis usually measured by a survival curve. So, prognosis and survival curves. The most common way we measure prognosis is with the survival curve. This slide shows survival data for one type of cancer measured by the stage at which the cancer was diagnosed. And like many cancers, the later the stage, the worse the prognosis. Patients diagnosed at stage one have a relatively good outlook. Their survival rate remains high over time, but as we move down the curve, survival decreases. And by the time the cancer is at stage four, the prognosis is much poorer, with most patients expected to die within about 7 years. Survival curves like this help clinicians and patients understand not only the seriousness of a disease, but also the impact of early detection and intervention. The earlier the disease is identified, the better the chances for long term survival. Now let's bring this into the world of clinical engineering. So, survival curves are also used to evaluate how medical devices affect patient outcomes. For example, studies of patients with implantable cardioverter defibrillators, or ICDs, show that survival rates improve significantly compared to patients who only receive the standard drug therapy. The survival curve demonstrates the life saving impact of the device, especially in patients at high risk of sudden cardiac death. And similarly, survival curves are often reported for patients on dialysis. These curves show how survival improves with early initiation of treatment and how outcomes differ depending on the type of dialysis technology that's used. So, whether we're talking about cancer stages or device supported care, survival curves gives us a clear visual way to understand prognosis and the role that medical interventions, including engineered technologies, play in extending life. Examples of prognosis studies. Let's look at a few examples of prognosis research. One set of studies focused on children who were extremely preterm, born at 25 weeks of gestation or earlier, and who had extremely low birth weight. And these children were cared for in neonatal intensive care units, and their long term outcomes raised many ethical and philosophical questions about how much intervention is desirable. And a 2005 study followed 241 children born this early in the United Kingdom and Ireland and compared them with their full term classmates at age 6. The differences were pretty striking. 41% of the preterm children had serious cognitive impairments, compared with only 1.3% of their full term peers. Prognosis studies like this provide critical information for both families and clinicians making very difficult care decisions. Another prognosis study looked at untreated early localized prostate cancer, and it followed men diagnosed between 1977 and 1984. many of whom today would have undergone surgery. Instead, this study gives us a window into the natural history of the disease. Over time, about 17% of men developed metastatic disease. The cancer spread beyond the prostate, and 16% eventually died from prostate cancer, but the majority did not. And so this finding highlights an important truth. Many men who develop prostate cancer will never die from it, and in some cases, the cancer doesn't even spread outside the prostate. Studies like this show how prognosis data helps us balance intervention with natural courses of diseases. And so when we look at this from a clinical engineering perspective, prognosis studies are also applied to patients supported by medical technologies. For example, long term survival has been studied in patients with ventricular assist devices, or VADs, which are implanted to support heart function. Prognosis data shows that for some patients, VADs serve as a bridge to transplant, significantly extending survival until a heart transplant is available. And for others, they function as destination therapy, where the device itself sustains life for years. Similarly, prognosis studies of patients on dialysis reveal how outcomes vary depending on when treatment begins, the modality used, and the patient characteristics. So these technologies focus prognosis studies are critical for clinical engineers and healthcare teams because they demonstrate how devices not only treat disease but also shape the long term outlook for patient lives. So, this concludes part five of our series on evidence based practice. In this session, we focused on two key types of clinical questions: harm and prognosis. Questions about harm ask whether exposure to a natural or man made agent, whether it's a drug, device, chemical, or environmental factor, actually causes disease. And these questions are most often answered with a case control study, though we also explored the strengths and weaknesses of other designs. So, questions about prognosis tells us the natural course of a disease, how it unfolds over time, and how interventions or technologies may alter that trajectory. Together, these approaches highlight how evidence based medicine equips us to weigh risks, predict outcomes, and make informed decisions for patient care. So that's it for this session, and I will see you. First of all, again, I want to thank you for your time, for listening to this session, and I will see you in part six.